very, very challenging patients. And then we have a special treat, a film of a psychopath who was treated by Truus Kirsten for 4 years with chemotherapy. And he comes back 2 years after his treatment is finished. He's out of the hospital, and he talks with Truus about his therapy and about her and about chemotherapy. And then after that, I'm going to invite Truus and Elsa Vandenbroek, Christina Esther de Vrijer, they're my wonderful forensic colleagues in the Netherlands who are doing chemotherapy with me, to come onto the podium and to answer your questions about what is it like to reparent a psychopath. Okay, all that in 45 minutes. Can we do it? Yes, we can. Okay. Okay, let's start with reparenting a psychopath. Is this an absurd idea or what? Have you ever heard of anything crazier than reparenting a psychopath? I mean, you think about your favorite psychopaths, you know, Hannibal Lecter, Jeffrey Dahmer, Mitt Romney. Nah, he's not quite there. Severe narcissist. Okay. In any event, think about your favorite psychopath. You know, this is a crazy idea, right? Everybody, reparent a psychopath? What's that about? Well, I have to say that for many people who are working in the forensic field, this would also seem like an absurd notion. Many professionals would see this as an absurd notion, although I have to say we're making some very good inroads in the forensic field, and I think some of these ideas are beginning to change. Okay, let's talk a little bit about psychopathy and what it consists of, and then we can see whether or not this is an absurd notion or not. Psychopathy involves a lot of features, both behavioral features, affective features, interpersonal features. But what many people feel is that the core features of psychopathy are really the personality features, the affect and interpersonal features. Like, for example, on the affective side, a lack of remorse, right? People who lack a sense of guilt, a lack of empathy, and an inability to empathize with other people. Psychopaths are seen as being emotionless, right? So these are people who don't have any feelings. And on the interpersonal side, they're highly manipulative. They can be very superficial, very charming. They've got an agenda. They're very good at getting what they want. They have a grandiose sense of themselves. They're very dominant, very controlling. And they can be extremely ruthless, right? So they can be exploitative, predatory. They take what they want, and they have absolutely no regard for other people's feelings or rights or needs. So if you just take a look at these criteria and you think about the idea of reparenting a psychopath, then you think, well, yeah, come on, who are you kidding? I mean, a guy like this is just a hopeless case. Now, the views of psychopathy that are in the forensic field really reflect this. Generally speaking, people are quite pessimistic with regard to the possibilities for treating psychopaths. First of all, for the last 200 years, psychopathy has been seen as essentially an inherited condition. You know, it's sort of the bad seed theory. These guys are born bad because they have bad genes, and they always will be bad. And there have been various, variations on this theme, and the latest is, has been developed by a lot of people who are taking a cognitive neuroscience perspective and actually doing very nice research on psychopathy that shows that they do have a lot of emotional deficits. They have a harder time recognizing, for example, facial and vocal expressions of emotion, that if you actually show them facial expressions of emotion, you have them in an fMRI scanner, that their amygdalas don't light up as much. So, there is some, and there is also some evidence that there's a strong genetic component to psychopathy. So there is some support in the literature for the idea that there are some, genetic, potentially, or at least biological components to psychopathy. There's also a belief in the field that psychopaths are difficult, if not impossible, to treat, and that treatment, in fact, will make them worse. Why? Because if you give them a psychological treatment, they're just going to go and all turn into little Hannibal Lecters, better able to con and manipulate you. Now, what's interesting is that there has been very, very little research, actually randomized clinical trials, that have actually attempted to use some kind of rational treatment for psychopathy and test its outcome. In fact, up until the study that we're doing, there's not been a single well-conducted clinical trial in this area. And so actually, the fact of the matter is that we just don't know. We don't know what the possibilities are based on empirical studies for actually being able to affect change in these patients. Now, the pessimistic view I already mentioned, then you can't do anything with these guys. In the forensic field, there is a kind of minority position that passes as the optimistic point of view. And the optimistic point of view is what's known as the no cure but control model. And that means, we can't really change the way psychopaths are, but maybe if they're motivated, like if they, they're tired of being in prison, they're tired of having lost everything, maybe we can help them to develop better social skills, learn to recognize some of their antisocial cognitions that tend to lead to crimes, and so that they can better control their antisocial behavior. Now, I have a feeling that for some psychopaths, and I think the literature supports this, that this model actually can be helpful for some of them so long as they are motivated. On the other hand, if your base position says these people cannot fundamentally be changed, then I think that that position essentially says we really can't expect very much from them. Maybe they can reduce some of their antisocial behavior to some degree, assuming that they're motivated to do so. Okay, so even the optimistic position, I think, is really not a very optimistic one. Okay, now let's turn to limited reparenting. We've talked a lot about limited reparenting in this conference. And limited reparenting is really based on the idea of reaching the patient's vulnerable side, right? That's the side of the patient, if you think in terms of the schema mode model, where, all of those unmet needs are located. All of those schemas, abandonment, mistrust, abuse, emotional deprivation, and so forth, okay? So we want to reach that side of the patient, and we want to provide some of what the patient has missed in order to start to heal them. But what if psychopaths don't have a vulnerable side, right? What if there's no vulnerable child there? Right? What if there's no vulnerable emotions there? I mean, that's the classic view of psychopaths, right? The classic view of psychopaths would lead us to believe that there is no vulnerable child. And so then how could you possibly do reparenting? And I think we have to say, honestly, that if there's no vulnerable child there, the idea of reparenting doesn't really make a lot of sense. And so then the question is there a vulnerable side? Well, one of the reasons why we think that there is a vulnerable side in many of these patients is because we see it. And I want to give you a few brief case examples where in psychopathic patients who tend in general to be very emotionally distant, cut off from their feelings, cold, and so forth, all of a sudden we see what appears to be a vulnerable side. So here are a few examples. One is of a patient that I worked with years ago when I was a psychologist up in the Bronx, working with drug addicts and antisocial patients. It was a long time ago. And this is a man who had been an enforcer in some criminal network. He'd gone around, hurting people when they wouldn't pay their debts and so on and so forth. Real tough guy. And he came down with AIDS, right? So this was back in the late 80s when there was really the AIDS epidemic in New York. And I remember meeting with him, and he actually started to talk about, in the course of my interviewing him, some of the people he had hurt. And he began to cry. And he started to express remorse. He started to say, I really wish I hadn't done some of those things. And I thought to myself, well, this is really interesting. I mean, this is a guy who was in a study I was doing at the time on psychopathy, and I had given him the psychopathy checklist interview, and I knew that he had a pretty high psychopathy score. And here he's expressing remorse, and he's crying and kind of tearing up, this big, tough guy. I'm thinking to myself, whoa, this is really strange. This kind of thing shouldn't be happening. Here are a couple of other examples. One patient who was in our study in the Netherlands, in the very first session, he said to his therapist, you really shouldn't bother going looking for emotions in me because I'm a psychopath and I don't have emotions. Well, a lot of the time, it really didn't look like he did have emotions. He was very flat and superficial in terms of how he dealt with people. And then one day he suddenly got sick and he had to be hospitalized. And he had a girlfriend outside of the clinic, and the girlfriend visited him in the hospital. And when the girlfriend walked into his hospital room, he started to cry. He started to cry. And afterward, when his therapist asked him, after he'd gotten out of the hospital and was back in the clinic, and his therapist asked him about this, he said, you know, don't really expect to see this side of me very often, he said. But, you know, he had acknowledged that there was this side of him, another side that one wouldn't normally see. And here's a third example. This is an example of one of Christina Esther's patients. This is somebody who had been doing very well, a psychopathic patient had been doing very well in schemotherapy, and then ended up taking some illicit Valium, I think it was, and he got disinhibited, and at a certain point his behavior started to get more and more out of control, and he hit a staff member. This is in one of these forensic hospitals. And so he was placed in separation. And you know, his therapist went and visited him. And instead of behaving in a judgmental way or a critical way, you know, she just really expressed caring and concern for him. And he broke down crying. Okay, so these are 3 examples, and I could give you many, many more examples. I mean, it's almost become a running joke in our study, the crying psychopaths, you know? We have some therapists who seem to be so good at evoking this side of the patient. We have 3 of them right here who you're going to meet later, where, you know, it's like almost like, you know, one guy after another comes out of the office, you know, the big tough guy is crying, you know? Well, I mean, how, you know, what is this about? I mean, is this possible? I mean, is this, well, what's going on here? Well, how can you start to understand in the context of, you know, a belief about psychopathy for 200 years that these people don't have emotion? How can you make sense of these observations of psychopaths having a vulnerable side? Well, in order to do that, what you need to do is make a fundamental shift in how you think about psychopathy. That the way in which we've traditionally thought about psychopathy has been a trait model. And the trait model essentially says that these people are the same way all the time. Right? So psychopathy is defined by traits like remorselessness and lack of empathy and so forth, and this is the way they always are. But one of the things that's really beautiful about the schema mode model that we use is that it's a state model. And it suggests that people have different sides of themselves, and that they may be capable in certain circumstances of reaching certain emotional states that they normally wouldn't. And if you go back to those 3 examples that I just gave, you know, what do all 3 of them have in common? If you think about the circumstances or the context for each of these people getting so emotional, it was a moment of sudden, unexpected vulnerability, right? Somebody gets sick, right? Somebody suddenly has an outburst and goes into separation, and there was something about that vulnerable moment that enabled them to get in touch with a more vulnerable side. And that's very consistent with the schema mode model, right? Which says that we all have different sides of ourselves. And so, just like other people, psychopaths also have different sides of themselves. And that they may actually be capable, in some cases, perhaps in many cases, of experiencing vulnerable emotions under certain conditions. And if you think about that, if it is possible to break through to the vulnerable side of a psychopath, then they may start to feel things. And if they can start to feel things, is it possible that they could develop empathy? And that they might even start to experience some what we call moral emotions, like shame or guilt. And if that were possible, could that potentially be protective in terms of their committing future crimes? Okay, so that's what we're after. Now, why, though, you know, if psychopaths are capable, or at least in some cases, of experiencing more vulnerable emotions, why don't we see that in them most of the time? Well, in our schema mode model, what we would say is that other sides of the patient are getting in the way. Right? So one of the things that we've done is develop a model of psychopathy where we talk about the presence of certain kinds of overcompensator modes in these patients, certain emotional states that they have developed as a way of turning the tables on other people, of taking the other hand, right? That is the kind of predominant way in which psychopaths cope. A self-aggrandizer side, a dominant or grandiose side of the patient, a side that puts himself above other people. a bullying side that uses threats and aggression to intimidate, an over-controlling side that focuses attention like a laser beam, a paranoid side that attempts to locate the source of a threat, a cunning and manipulative side that plays a certain kind of role, a kind of a play actor in order to get what he wants in an indirect, covert way, and a predator side, a side that can be cold and ruthless and calculating, to eliminate a threat, eliminate a rival, eliminate an obstacle to getting what he wants. Okay, so in our model, psychopathic patients are people, if you take a look at what's underneath those overcompensatory modes and also behind these various avoidant modes, they're the child side of the patient. If you look in terms of the histories of these patients, what you see, and this is very consistent with Guy's talk, is very severely disturbed attachment histories in these people. You know, these are patients who very often had no one in their lives who cared about them. You know, they were chronically, repeatedly abandoned. These are people who are often very severely abused, physically, emotionally, or sexually. You know, people who grew up in highly chaotic, unpredictable environments. And if you think about the attachment styles that, you know, Guy was showing, you know, many of them have a disorganized attachment style, a dismissive attachment style. There's a lot of research on psychopathy that supports that. So what that suggests is that there is potentially, you know, there are these child sides of the patient, an abused, humiliated, or abandoned child side, a lonely child, also an impulsive and angry child side, but that these are often hidden behind these other modes. And so a lot of what we need to do is to try to bypass these modes that are blocking access to the vulnerable side in order to reach it, so that we can do that reparenting. And when you really take a look at the number and severity of these modes, then it becomes quite clear what a challenge that is, right? This is not something that's going to be easy to do. But is it possible? Well, you know, it's possible. We're seeing it clinically in many of our patients, but you know, I just want to very quickly show you a little bit of experimental evidence that also suggests that it's possible to do. You know, can we see vulnerable sides in psychopathic patients? Well, this is a slide based on some research that's being done by one of my PhD students, Mariah Colin-DeVos, along with Elsa Vandenbroek and other colleagues. And it's an experimental drama therapy protocol that we've developed to try to evoke the vulnerable side in antisocial and psychopathic patients. I won't go into the details of it, but it's based on, actually Elsa helped us to develop this protocol. And what I'm showing you here, this graph, is from the third session from this 5-session protocol, which is specifically designed to evoke the patient's vulnerable side. And essentially what the drama therapist does in the previous session, she will have used a technique called the family table, where she asks the patient to play out a scene from childhood around the family table. She uses that as a way of identifying the unmet needs of the patient in childhood. And then in the next session, which is this one here, she actually, again, plays out that scene with the patient in order to get to the core unmet needs, and then does re-scripting via role-playing to try to help to provide for some of those needs. Now, what we've done here is we trained students to rate schema modes during these sessions. So we videotape these sessions, and then we have students rate schema modes on a minute-by-minute basis using an instrument that we developed called the Mode Observation Scale. And so what you're seeing here are minute-to-minute ratings, and all we've graphed are vulnerability ratings, and anger, vulnerable child and angry child. Now you see there's no angry child here. This is a patient with a psychopathy checklist score of 32. Now, the psychopathy checklist is sort of the gold standard interview for psychopathy. Anybody with a score of 30 above is considered a bona fide psychopath. Okay, a score of 25 or above is even indicative of significant levels of psychopathy. So this guy here is the real deal. Now, this is not a schema therapy patient. This is a guy who actually had only been in the clinic for a short while. He hadn't had any really significant psychotherapy up until this time, so we deliberately chose patients who are relatively therapy naive. And take a look at these ratings. The mode observation scale is rated on a 5-point scale from 1, which is a complete absence of that mode, to 5, which would be an extremely high level of intensity for that mode. And these are the minute-by-minute ratings over 45 minutes of the session. And all of these blue lines indicate the presence of vulnerable child mode. Okay, so what you're seeing is, moderate levels of vulnerability in this patient during this drama therapy session. This is a psychopathic patient. So this is the first experimental evidence that we have that we can actually evoke the vulnerable side of in a psychopathic patient. So we're now starting to then have some experimental confirmation for what we're seeing in our psychotherapy sessions. Now, how does one go about reparenting a psychopath? Well, I'm only going to go over this rather quickly now because we're going to have our 3 experts here in a few minutes to also help to answer this question. But one of the things that's perhaps the most important thing is a persistent focus on attachment and experiencing emotions. Okay, these are people who are very emotionally walled off, and they are highly, highly mistrustful. If you had to talk about a single early maladaptive schema that's really central in these patients, it would certainly be the abuse mistrust schema. Okay, so what you have to do is be extremely patient and persistent with them and work slowly over a period of a year to a year and a half before you're going to really break through to vulnerable emotions in many of these patients. Now, sometimes it happens more quickly, but in any case, the therapist has to really be prepared to hang in there. And then a lot of what you need to do as the therapist then is also to make use of schema mode work. So in the beginning of the therapy, we teach the patient the schema mode model, and very interestingly, these patients will mostly readily acknowledge these modes like the bully and the conning manipulative side and the predator. Oh yeah, I have a predator side, absolutely. They recognize it. And once you've introduced that model, the beauty of it is that the therapist and the patient can talk about it. And eventually, the other people who are treating the therapist, like treating the patient on the ward, can talk with the patient about those modes too. And then you end up doing a lot of empathic confrontation and limit setting, particularly in the here and now of the therapy relationship. What is the mode, what's the side of you right now that's trying to back me into a corner? What's the side of you right now that's trying to get this kind of special privilege from me? What is this side? Okay? And then we make extensive use of experiential work, like, as you know, the imaginary rescripting, role-playing, and so forth, in order to, again, break through to emotions in these patients. Okay, now I'm not going to say anything more about the details of how we do the reparenting, because then we'll have a chance to talk in a few minutes with our experts. Okay, now, let's see, how are we doing on time? How much?
In total?
Yeah. 10
10 past 11.
past 11. I have about 15 minutes. Okay, so I'm going to make this quick then. We're doing this randomized clinical trial, and we've been doing it since 2007 in the Netherlands. It involves 8 different forensic hospitals. The Royse Wissel in Venray, the Van der Hoeve Kliniek, the Oostvaarders Kliniek, the Mesdag Kliniek, Veldzicht, Asse, and the Royse Wissels branch in Maastricht, known as Overmaze. We randomly assign patients to either get schema therapy or usual forensic treatment at each of these institutions. It's been a really long haul to get to a sufficient sample size. There's been a lot of institutional barriers, but at the same time, a lot of cooperation with these institutions. And we're now up to 101 patients enrolled in the study. We're almost finished with our recruitment, so we'll get up somewhere in the range of 101 to 105. It's a little lower than what we had hoped to for our power analysis. We were hoping to get up to 114, but nevertheless, this is far, far more than has ever been done in a randomized clinical trial in the forensic field with this kind of population. And so we're looking at a variety of different kinds of outcomes in these patients. And I won't go through all the details, but I want to show you, among other things, some of what we're finding. We've already have 30 patients who have completed the full 3-year treatment. It's a 3-year treatment. The design is very similar to the design from Arnout Arntz and Josephine Hiesenblau's original 2006 study. So they get 3 years of chemotherapy or 3 years of usual forensic treatment. We look at a variety of different outcomes, including using a standardized risk assessment measures to look at their level of risk. We also look at their progress in what's called resocialization. Resocialization means going through the process of being reintegrated into the community. In these forensic patients, if the patient's risk level has been lowered sufficiently, then they receive permission to begin to leave the institution, first for very brief periods of time under high supervision, and if that goes well, then eventually for periods of unsupervised leave. And this process of resocialization takes place over a period of 2 to 3 years. And so whether the patient gets into the resocialization phase is critical. And the reason is because if they never get to that point, then eventually the system gives up on them. And they're sent to something called long stay. And long stay basically means locked up, throw away the key. So there's a big incentive to get these patients out of the institutions, but only if their risk level, their risk for future violence and future crime has been sufficiently lowered. Now here are I'm going to show you very quickly some of the results in our first 30 patients to have completed the study. These happen to consist of 16 patients in the chemotherapy condition, 14 patients in the treatment as usual condition, and just by chance, in this small sample, a much higher percentage of high-scoring psychopaths ended up in the chemotherapy condition. 5 out of 16 had a score of 30 or higher in the chemotherapy condition, and only 2 out of 14 in the treatment as usual condition. Now those differences will even out over time. When we have a larger sample, we'll see that they're going to end up being quite comparable in terms of their level of psychopathy. But in looking at the next graph, please keep in mind that the chemotherapy patients here are more psychopathic, at least in this small subsample. Now these are risk scores, HCR20 risk scores, over a period of 3 years, starting from baseline all the way to 36 months. And a score of 0 means low risk, a score of 1, medium risk, and 2 is high risk. Here are the chemotherapy patients with higher psychopathy scores, with scores of 25 or higher. Here are the treatment as usual patients with scores of 25 or higher. Notice that the chemotherapy patients are starting out with a much higher level of risk. They're starting out on average in the high risk category, whereas the treatment as usual patients who are more psychopathic are starting out in the moderate risk category, right? That's just, again, due to this fluke of the randomization in this small sample. The chemotherapy patients are starting out more at a disadvantage. It's like running a race where you're starting out further behind the starting line. Now look what happens over the first 18 months of treatment. These are the highly psychopathic patients in the chemotherapy group. They are rapidly improving to the point, by 18 months, halfway through the treatment, they've caught up to the treatment as usual patients who are highly psychopathic. Okay, so this suggests, and this is not yet a statistically significant difference, but if this holds up, what it suggests is that chemotherapy is working more rapidly to reduce risk in highly psychopathic patients. Now, this is also consistent with our findings regarding patients' progress through the resocialization phase of treatment. Again, starting with time 2 here, which is 6 months, all the way to 36 months, and the light blue bars are chemotherapy, the dark blue treatment as usual. What we're seeing is that every time point, the chemotherapy patients are more likely to have received leave, both unsupervised leave and supervised leave. In other words, that a higher percentage of the chemotherapy patients are moving into and through the resocialization process. And of course that makes sense because their risk levels are going down. And these are the same instruments that the institutions use in order to make decisions about who gets to go on leave. And if you look at the speed with which they go on leave, this is supervised leave, and this is unsupervised leave, we see the same thing, that the schema therapy patients are getting leave more quickly, an average of 4 to 6 months more quickly. And one of the advantages of that is in terms of cost effectiveness. Forensic treatment is very expensive. In the Netherlands, 1 year of forensic hospitalization costs 160,000 euros per patient. That's a lot of money. Well, we did some calculations that showed that the entire cost of treating one patient in schema therapy for 3 years in these institutions, including training and supervision and the salary of the therapist for the time he's doing the therapy, can be recouped fully if you reduce their length of the institution by only 2 months. And we're, it appears, going to be reducing it by at least 4 to 6 months. And that does not even include the amount of money that's saved if schema therapy proves to reduce recidivism. Think about the enormous costs of crime. This doesn't even take that into account. So schema therapy has the potential to be highly cost effective.